So I graduated from the University of Sydney in Australia last year, 2022. I grew up in Canada. I'm Canadian. I spent 4 years in Australia. These are some photos from when I was there. For those of you who visited, it's a beautiful country with many beautiful beaches, very wonderful people, incredible sunsets, very cute animals, some kangaroos. And yeah, I highly recommend everyone visits. Me and Dr. Lisa definitely bond over our time in the South, her being a Kiwi, which for those of you who don't know, that's what we call people who are from New Zealand. So that's a very small introduction. I'll go ahead and start with the presentation now. I'm just going to share part of my screen. Departments are all It's been a while since I've used Zoom, so it will take me a moment. All right. So the article that we're doing today is Management of Endodontic Emergencies, Pulpotomy versus Pulpectomy from the American Association of Endodontists, published in fall 2017. This article, the content that we're going to go over today is fairly straightforward. It's not too complicated. I've got a quick summary of the article, and I've got a series of questions afterwards for us to review our memory, revise our memory, and try to challenge ourselves a little bit. Hopefully everyone benefits from it, and we can have a very productive conversation at the end. So, starting off very broad and quick overview of dental emergencies. So this whole article is about, when a patient comes in pain and you evaluate them, according to the journal article, 60 to 82% of those dental emergencies are actually endodontic. So it's quite a large amount, and it's quite a large proportion of patients who come in who we have to deal with, who are in endodontic pain. And from the 60 to 82% of emergencies, 20 to 42% of them have symptomatic irreversible pulpitis. So it's quite a very large proportion. And from all of those patients who do have symptomatic irreversible pulpitis, 60% of those patients with symptomatic irreversible pulpitis have symptomatic apical periodontitis. So I think in addition to these statistics, I think we can all, we all have anecdotal evidence from our own experience of these that are true to these statistics. So what is the goal of emergency treatment? When our patients come in and they're in this pain and we diagnose them with either irreversible pulpitis or symptomatic apical periodontitis, really the goal of these emergencies is for us to quickly and effectively manage the pain and effectively manage the infection as well. So two objectives. We want to minimize the development of persistent pain, and we want to get our patients out of pain. We want to make sure our patients are comfortable. And additionally, we also want to reduce the formation of periapical pathology and reduce the spread of infection. So in the article, they mentioned there are many different methods of doing this, right? Very early on in the article, they do mention that pharmacological management is definitely an option. So pharmacological management, for example, intramuscular or infiltration injection of ketorolac, which is an injectable NSAID. That's one way of managing the pain of the patients. Or you can also just do oral administration of ibuprofen. Now, interestingly, they said in the article that these treatments have actually only been evaluated specifically to endodontic therapies over a few hours. So they have not evaluated the effectiveness of pharmacological management over days or weeks following an endodontic emergency. So for that reason, procedural interventions remain the gold standard for managing endodontic emergencies. So even though we will talk in a little more detail about pharmacological interventions and other adjunctive therapies, the gold standard really when you have a patient in an endodontic emergency is to intervene with a procedure. So let's talk about a couple of those options for what procedures we can intervene with. Obviously, as the title says, we're going to be talking about the options of a pulpotomy or a pulpectomy. So pulpotomy and pulpectomies, they differ essentially in that a pulpotomy protocol is limited to the removal of inflamed tissue, and that's restricted to the pulp chamber. While a pulpectomy, the protocol requires the extirpation of the inflamed tissue in the root canal system. Although pulpectomy, the terminology is suited for vital pulps, it is applicable to both vital pulps and removal of necrotic tissues from root canals. So you can use pulpectomy to refer to vital or non-vital therapy. Interestingly, something I found interesting in this journal article is that it said that most endodontists or more endodontists actually are inclined towards pulp extirpation or pulpectomy rather than pulpotomy only procedures for both vital and necrotic cases. And in the article, it actually listed that apparently the primary reason for performing a pulpotomy or a pulpectomy, the deciding factor was usually insufficient time, according to this journal article. So that said, that's something to keep in mind through the rest of the presentation is that, insufficient time, it could be a factor in deciding whether to do a pulpotomy or pulpectomy. But I will also go over much more like specific indications for either one of these. Another thing to note that I thought was interesting to highlight in this article is that more than 50% of endodontists actually prefer complete instrumentation compared to pulpectomy only procedures, especially in necrotic cases. So if you're going to do a pulpectomy, it seems that it's actually better to do complete instrumentation with that pulpectomy rather than just a simple pulpectomy with incomplete instrumentation. And the reason for this is because it provides much more effective antimicrobial management, and it more effectively manages both pain and spread of infection by doing that complete instrumentation. The shift in the preference is likely because there's also been an increase in the literature on the effect of complete instrumentation and the placement, of course, of an intracanal medicament on the reduction of the bacterial toxins and cytokines that directly activate the nociceptors. Now, all of that said, so that was kind of like a big introduction to, and also, highlighting the main ideas in this journal article. Now, there are many emergency cases that come in with pulp pain and symptomatic apical periodontitis that can be treated and completed in one visit. So there are certainly scenarios where you can do endodontic treatment in one visit when they come in. But this article doesn't really go into that. This article is more about specifically pulpotomy versus pulpectomy. So just keep that in mind. We won't cover like every possible endodontic emergency, but we will cover when to do these specific endodontic interventions. So let's talk more specifically about pulpotomy and that option. So as I said before, pulpotomy is removal of the coronal part of the dental pulp, followed by application of a medicament. When you do a pulpotomy, something to keep in mind is that, the first thing you would do, of course, is anesthetize the patient, put rubber dam, and you would first do caries removal. And if you can manage to do the caries removal before you expose the pulp, that's better to try to keep it sterile. The other thing is when you go to access the chamber of the pulp, it's possibly better to actually do that with a slow speed round burr in order to minimize the trauma that you're doing onto the tooth and onto the nerve. Because of course we are going to be maintaining a portion of this nerve is going to stay there and it's going to be vital. So trying to access with slow speed rather than high speed and doing your best to be atraumatic in a way is good in order to, try to increase chances of success of your pulpotomy. So as I said before, in this article, they said that the primary reason for doing a pulpotomy over complete instrumentation is the lack of sufficient time to clean and shape canal systems. But despite that, there are specific indications. So I think in this article, they were often referring to permanent teeth. So if you were to ever do a pulpotomy on a permanent tooth, the main reason for doing that would be that you just don't have sufficient time. If you don't have any time and your patient is in a rush or for whatever patient-related reasons, you can do a pulpotomy to manage the pain. But then, of course, you would medicate and bring them back to do the rest of the endodontic treatment. And of course, that is different to when you're doing a pulpotomy on a deciduous tooth or a baby tooth. So going over the indications for doing a pulpotomy, the indications are obviously as listed. So you would only do a pulpotomy if it's a vital tooth. If the periodontium is healthy, you need to make sure there's only coronal involvement. So even if there is caries, it can't be caries beyond the coronal involvement. If you have a contraindication to extract the tooth, you could consider a pulpotomy. If you were to do a pulpotomy, there has to be absence of infection or abscess, no fistula, no spontaneous pain, no involvement of the pulp floor, and no interradicular bone loss. So it has to be a fairly healthy environment, almost in a way. You could think of it that way in order for you to be indicated to do a pulpotomy on a deciduous tooth. Possible complications of doing a pulpotomy are you could have anesthesia complications, you could have trouble numbing them, you could have tooth fracture, tooth discoloration, and you could also have persistent pain. All right, so that's pulpotomy. So pulpectomy, which is instead of just removing the coronal portion, you're removing the whole contents of the pulp chamber and its root canal. So the common theme between pulpotomy and pulpectomy and any endodontic therapy is microbial control. That's the most important thing, is microbial control. So in both the scenarios, you will be medicating. And I'll go into medications a little bit. So the indications of pulpectomy, you would do them on, for example, non-vital teeth, if they have furcation involvement, furcation radiolucency, coronal and radicular involvement, extensive caries, if you have a dental abscess, if you have irreversible pulpitis, if you have a primary tooth with necrotic pulp, if you have pulpless primary teeth, but you need to maintain the arch, and you cannot do a pulpectomy if there's an underlying cyst. The complications of doing a pulpectomy are very similar to a pulpotomy. So you can have adverse effects of anesthesia, you can have tooth discoloration, you can have local infection, pain, bleeding, tooth fracture, and tooth loss. So very similar to general endodontic risks and complications. So in the article, it does emphasize that there's a greater number of endodontists that use calcium hydroxide as an inter-appointment medicament. And that's something to remember when we go over the quiz question, the multiple choice questions later. But obviously calcium hydroxide, owing to its bactericidal and detoxification effects, is the most commonly used intracanal medicament. So when we talk about one visit versus two visits, it has to do with patient-related factors, and it can also have to do with tooth-related factors. So I've listed this example here. In this example, it was an emergency appointment where the patient reported a 4 out of 5 pain scale, and this patient was diagnosed with typical symptomatic irreversible pulpitis with symptomatic apical periodontitis. When the dentist accessed this tooth, possibly with the intention of doing either possibly a pulpotomy or a pulpectomy, once they accessed, they saw a mesiodistal macroscopic fracture. And then further visualization was done with methylene blue staining, and that revealed microscopic extension of that fracture line into the distal buccal canal orifice. So that tooth was then deemed non-restorable. So at that point, they performed a partial pulpectomy only to avoid enlarging the root fractures, and then an immediate referral was made to the oral surgery clinic. Figures B, C, and D are similar. Like they're also showing fracture lines that can only be seen after you've accessed the tooth. Even though we do have a lot of diagnostic tools such as the tooth sleuth, we've got transillumination and in order to visualize large fractures. We've got loops, of course, but you can't always see how deep the fracture lines extend, and sometimes you don't see them until you're already in the pulp chamber. So that's why an emergency appointment is the perfect opportunity to evaluate the overall survivability of the tooth. And so that's something that's important when it comes to deciding whether to do a pulpotomy or a pulpectomy, because you have to keep in mind, even if you've told the patient that you're going to do that, but then you go ahead and open the tooth, you may run into these complications and then the plan is going to change. In this scenario that I mentioned, even though they saw the fracture line, they were not able to do the extraction at the time. So they did go ahead and do a partial pulpectomy in order to manage the symptoms until the patient could go and get the extraction done. So speaking of, complications of endodontic therapies and complications when managing endodontic emergencies. I'm going to go into a little bit about adjunctive therapies. The first one I'll talk about is, having access to CBCT, which is a big advantage, but not one that we all have. This case in particular, it shows the advantage of having CBCT imaging. So they took a couple of X-rays in the top row. This patient had a 4 out of 5 spontaneous pain, and it was diagnosed with symptomatic irreversible pulpitis and symptomatic apical periodontitis. So the pre-op radiograph showed an unusual second molar anatomy. There were certain ramifications. There was an indistinct furcation, an indistinguishable apical extent, the apex. So these features sometimes can be consistent with a C-shaped canal anatomy. And the incidence of a C-shaped canal anatomy is very low. It's usually around 5 to 10%. Therefore, a CBCT scan was taken in order to confirm the anatomy. So it was confirmed it had a continuous C-shaped anatomy, and it only had 1 millimeter thickness on the lingual dentine wall. So because of the complex anatomy of such a tooth, there are obviously going to be additional challenges for the clinician. So at this stage, it might not just be a simple pulpectomy, quick and easy. It might get a little bit complicated. So what happened in this scenario was that they looked at all the anatomy in order to be able to complete adequate instrumentation. And there was careful decision-making with respect to the prevention of iatrogenic complications, such as strip perforations, especially on that thin lingual side, the lingual wall. And to avoid further distress to the patient, they also used supplemental anesthesia using intraosseous technique, as well as intrapulpal anesthesia. So in summary, I like this case in particular because it showed that, you need to always make a well-informed decision. And when you go, in order to make a well-informed decision, you sometimes need to employ advanced tools such as CBCT. In this scenario, once they discovered the anatomy, they went on to use ultrasonic instruments in order to instrument the lingual aspect conservatively. And then at that visit, once they completed that pulpectomy, they medicated with calcium hydroxide, and that patient was completely asymptomatic after the appointment. So this case was then completed at the second visit with no complications. Perhaps it's possible to think, without that CBCT or without noticing that unique anatomy from the beginning, they may have completed a pulpectomy, but they may have ended up doing a strip perforation across the lingual wall, or they may not have achieved that pain relief for that patient because of missing some of that anatomy. So the moral of the story here is that, when you can do a pulpectomy, but not all pulpectomies are the same, basically. This is another scenario showing basically using multiple methods of managing your patient's pain. Basically showcasing that, it's not always going to be just a pulpectomy. Sometimes you're going to have to use many different tactics and strategies in order to get your patient out of pain. So in this case scenario, there was a severely infected tooth with a lot of pain, 4 out of 5 pain. 2 weeks ago, there was a partial pulpectomy that was performed, and that partial pulpectomy was inadequate because the patient showed up again now still in a lot of pain and having an intraoral swelling. So they had intraoral swelling, localized fluctuant, and they also had an extraoral swelling. The tooth was then diagnosed as previously initiated therapy with an acute apical abscess. Once they accessed, as you can see in figure B, there was a large amount of purulent drainage. The tooth was allowed to drain for 20 minutes with continuous irrigation and suction. Once they observed that the drainage was completed, then they continued. Complete instrumentation was then completed, and that was followed by placement of calcium hydroxide and an intact coronal seal. In addition to completing the pulpectomy, and it wasn't just a pulpectomy, it was complete instrumentation. In addition to that, they also drained and incised. So they did an incision and drainage on that intraoral swelling. And then in addition to that, they also prescribed the patient a 7-day course of penicillin, Pen B. And then treatment was completed at the second visit with no persisting soft tissue abnormality and no more purulence within the system. So here, not only did they do a pulpectomy, they did a complete instrumentation, and they also did incision and drainage, and they also gave antibiotics. So they really managed this patient very well with 3 different adjunctive therapies, especially given the fact that this patient 2 weeks prior had already gone in for a partial pulpectomy, which was not adequate enough to handle it. So the moral of this case is that it isn't always going to be enough to just do a pulpectomy. And you should also be very careful with just doing a pulpectomy or a partial pulpectomy. Most endodontists prefer doing complete instrumentation rather than simply just pulpectomy. And that's been shown to be more effective at pain management and infection management. So let's go over some more of those adjunctive therapies that I kept mentioning. So one thing you can do is occlusal adjustment. That's been shown to significantly reduce pain in patients with vital pulse and periradicular symptoms and pre-op pain within 2 days. The next thing you can do is post-operative analgesics. So most commonly, people prescribe ibuprofen 600 milligrams or ibuprofen with acetaminophen combination, which is the most effective at managing post-op pain. There's also a newer ibuprofen formulation called ibuprofen sodium dihydrate, and that's been shown to have a faster onset of action than ibuprofen acid, producing a greater reduction in spontaneous pain and basically giving your patients more comfort. I've personally never used that new formulation. I don't know if anyone's ever used ibuprofen sodium dihydrate. Drop it in the chat. Let us know if you use it or if you think it's better. Personally, I've only gone with the classic ibuprofen acetaminophen combination. The next thing you can do is an incise and drain. It's indicated when you have a localized, firm, or fluctuant soft tissue swelling. And it's extremely effective because it will release the fluid pressure from the tissues. It'll reduce microbial and inflammatory mediators, and it'll prevent the spread of infection to deeper facial tissues. So that's always important to keep in mind doing that when it's indicated. Alrighty. So the last thing on this list you'll see is post-operative antibiotics, and that gets its own slides because antibiotics, is a very hot topic in my opinion. Maybe I just like talking about it. So with post-op antibiotics, obviously you need to be very careful. It's your responsibility to try to observe for any systemic involvement in all of your patients. So any cases of an acute apical abscess with an intraoral or extraoral swelling, any lymphadenopathy, and any fever, those are critical signs that you cannot miss. And those are the signs that if they're there, that's when you would need to give post-operative antibiotics. Those cues indicate that the infection from the pulp and the periradicular tissues could be spreading deeper and could be dangerous to the rest of the body, and that needs to be arrested immediately. So let's look at this list of antibiotics. When you have those signs and you need the best possible antibiotic therapy, the studies show that the most effective antibiotics for endodontic pathogens are either amoxicillin and clavulanic acid, which is augmentin, or you can also do a combination of amoxicillin with metronidazole. So those are the most effective antibiotics prescribed for endodontic pathogens. Now, despite all of that, there's no evidence to suggest that antibiotics reduce pain or manage pain, and therefore overprescription of antibiotics in the absence of systemic involvement is you must avoid that, because obviously then you'll start causing antimicrobial resistance in patients. So antibiotics is something I think some people might overprescribe. And so it's very important for us to know exactly when to use it. And I'll bring this up again at the very end of the presentation because I'd love to have a discussion about it. Me being a new graduate, I'm only about like 9 months into working. I've definitely noticed some people use antibiotics a little bit more often than other clinicians. And so I think that's very interesting. I'd love to, have a discussion about it and hear some thoughts about when other people prescribe it, specifically for endodontic emergencies and also for non-endodontic emergencies. So in summary, why is this important? Why is it important for us to go over these things, even if they may seem a little bit basic? Endodontic pain is a result of a combination of factors. So it's a host-mediated inflammatory response that causes nociceptor sensitization, combined with mechanical pain from the pressure buildup in the periapical tissues. So since pain relief with analgesics and painkillers is usually short-lasting, it is very, very important for us to know these procedures, the pulpotomy and the pulpectomy, because these procedures are required for definitive treatment. The primary goal of these emergency procedures is to provide significant relief of pain for a sufficient duration until definitive treatment can be delivered. However, clinicians must also keep in mind a couple of other objectives that they can achieve when they see these emergency patients. They've got a few goals when this emergency patient walks in. Your first goal is to deliver care that's going to prevent the development of persistent pain and prevent the continuation of periapical pathosis. And therefore, that will increase the chances of success of your future endodontic treatment. Your second goal is to take all measures to prevent systemic involvement. And your third goal, which is very important, is to use this time in this emergency visit and in this pulpotomy or pulpectomy procedure to determine the overall survivability of the tooth in question. So that's another advantage of these procedures. So in summary, effective emergency care can often save the natural tooth and can often provide decades of service to our patients. And so that's really all it is in the end is, we want to help our patients, we want to get them out of pain, and we also want to give them the most successful possible chance of keeping their teeth for longer. So that's my presentation. I think I may have spoken fast, so it may be under 30 minutes. I thought it would be 30 minutes, but I do have many multiple choice questions, so I'll move on to those if that's okay. The first one is a case. So I'm not sure if Dr. Lisa, if you're going to put up a poll or if it's okay for me to just have it on my slides.
You can go ahead and do it on. I'm still experimenting with the polls, so I haven't quite got that. You do have a lot of questions here, so I think we're going to be pretty occupied with your questions for the rest of it. So why don't you go ahead and start, and yeah, we'll just do it that way. Maybe people can answer in the chat.
Mm-hmm. Okay, perfect, awesome. Yeah, the article was fairly already a summary in itself, so it was a little bit difficult to get 30 minutes out of it, but I enjoyed making the questions, and I personally learn and remember more from questions anyways. So I thought it would be more beneficial for us to go over questions instead of this content. So the first one is, very quick scenario. Some of these questions I came up with myself, and some of these questions are actually from my Canadian board exams that I recently wrote. I'll pick out a name, but if everyone can, maybe I'll give like 20 seconds for everyone to put their answer in the chat so everyone has a chance to answer, and then I can pick someone out to maybe like explain what they think the correct answer is. So I'll read it out. The most appropriate management for a 4-year-old patient with a primary molar that caused a severe throbbing toothache the previous night is either A, prescribe an analgesic, B, an antibiotic, C, remove caries and place a restoration, D, perform a pulpotomy, or E, perform a pulpectomy. Okay, so majority of the people answered E and one person answered D. 2 people answered D. Okay, so we've got a little bit of controversy here, which is what I was hoping for. um, would anyone like to volunteer to make their argument before I pick on someone? This takes me back to university days.
I think it's a contraindication to do like if I'm in between pulpotomy or pulpectomy, it's a contraindication to do pulpotomy if the patient has a severe throbbing pain. So that's why we would go into pulpectomy. It's most of the nerve has been affected. So
Yep, very excellent answer. So you are correct. It is pulpectomy. If your patient had severe throbbing pain, like you said, or spontaneous pain, then that is a contraindication for pulpotomy, but that is an indication for pulpectomy. Now, interestingly, actually, I'll do a follow-up question for you. So this patient is 4 years old with a primary molar. Would you opt to do a pulpectomy, or would you opt to extract the tooth? And why?
Speak to the same person. Speak to Dr. Ithar. Go for it.
okay. So what I would say, I know it's a controversial thing. I would personally go for an extraction. I've had some pediatric dentists saying that I have worked with, and I think it's that they say the success for the pulpectomy is like is not as great, and so eventually they'll do the pulpectomy and then they'll end up doing the extraction. So I mean, the advice that like it's as if it's more from experience, honestly, but I know it's like there are some who would prefer pulpectomy, keeping the tooth, but it can be dental related too, it can be case related too. I think it also depends, like if let's say there's no permanent tooth and it's the primary tooth doesn't have a permanent tooth, then I would think we would do everything we can do to keep it, right? I think that's what I think. Anyway.
Yeah, no, excellent answer. I personally agree with you. Having done a pediatric rotation in dental school pretty recently, I noticed most of my pediatric, instructors, they used to generally also lean more towards an extraction over a pulpectomy for the similar reasons as you said. But also it is definitely case by case. It's always case dependent. So that I don't think that's a general rule, but I do think, depending on the patient, sometimes it is possible that you might opt for an extraction over a pulpectomy. In dental school, we didn't In my dental school, we didn't see too many pulpectomies. It was usually either a pulpotomy or an extraction. So yeah, thank you for sharing, Dr. Ithar.
I have a question regarding this.
Mhm.
Or rather, I would like to say something that I'm thinking about is that with primary teeth, mostly we have slender roots, and the anatomy is such that they're very divergent, like, far apart. The furcal area is pretty thick. So, with that kind, I would prefer a pulpotomy, or if need be, like, extraction in a space maintainer. Also, for a 4-year-old, I would take my time going for extraction just because, the tooth bud is still far away, is not very near. And then with any kind of infection or periapical pathosis, we're still okay. But then it also depends on the tooth stages, right? The development still stages for the permanent. So it's like it's not that simple to just think about pulpectomy or pulpotomy. It's always like case to case, scenario based. But like usually I've seen pulpotomies and extractions in space maintainers.
Mhm. Yeah, thank you for sharing. That was really like beneficial knowledge to know. I do agree, especially when it comes to managing like a 4-year-old, you definitely have to be very careful, right? And you also never want to traumatize a child. So it is very tricky. And then just to add on to the anatomy part, in that, in addition to it, it's already a difficult route. There's also a lot more accessory canals in the furcation area. And I think that's another reason why performing a pulpectomy on a primary tooth can be difficult, because it's very, very difficult to actually get your medication into those accessory canals in the furcation area. So yeah, very good contribution. Thank you. Okay. So the next question, so I've got quite a few easy questions and then a few slightly trickier ones. I felt like people would be tired after work, so I didn't go too hard here. So what is not an indication for pulpotomy? So this is just triggering, trying to trigger your memories. Since we already went over this, it was on a slide. So let's see how much you guys remember. So what's not an indication for pulpotomy? A, caries in the coronal portion. B, iatrogenic pulp exposure. C, large restoration causing irreversible pulpitis. D, irreversible pulpitis. Oh, there's a poll. E, spontaneous pain. So read the question carefully. This is, what is not a contraindication for pulpotomy? It's a bit of a double negative. So basically, think about a pulpotomy. What is not a contraindication to doing a pulpotomy? A, swelling or fistula. B, pulp exposure due to caries. C, involvement of the pulp floor. D, pulp calcifications. And E, excessive hemorrhage. So question 4, this is the last one of this type. So what is not an indication for pulpectomy? So now we're talking about pulpectomy and the indications for pulpectomy. So A, vital teeth. B, underlying cyst. C, excessive hemorrhage. D, periapical pathology. E, non-vital teeth. And F, furcation involvement. What is the best antibiotic for post-operative endodontic management? Again, straightforward, just testing your memory here, testing if you guys were paying attention when I was speaking. Augmentin is what we call amoxicillin plus clavulanate or clavulanic acid. Next question. When should you use post-operative antibiotics? So I will read through this. It's going to be a mouthful. So there's 5 scenarios. The first one is an 80-year-old with necrotic pulp with a chronic apical abscess and draining fistula. B is 75-year-old with necrotic pulp with an intraoral swelling. The patient is a 9 out of 10 pain. There's no fever or lymph involvement. C is a 45-year-old with irreversible pulpitis with intraoral swelling, and the patient is a 9 out of 10 pain. There's no fever or lymph involvement. D is 10-year-old with irreversible pulpitis, no swelling or radiographic pathosis, and a mild fever. And E is a 9-year-old with irreversible pulpitis with acute apical abscess, facial swelling, and mild
I
fever.
don't like the word mild fever. I don't think it does exist. You're either feverish or not, right? By definition. I don't know of anybody who can agree to fever, mild fever. Like, you know, it's a temperature that we all agree on, right? And it's above that temperature, it's fever. Below that temperature, there is no fever, right? So unless if it's something that I don't know, but I really probably will omit the word mild fever, just keep it fever, right? You know, but it's like mild fever is, what is the mild fever? Like, you know what I mean? So you either have, if you have a raised temperature, it doesn't mean that you have fever, right? So if you know what I mean, right? There is a number that we look at, and above that number, it's fever. Below that number, it's no fever.
So on the topic actually of fever in general, I thought of this question, Dr. Hassan. What happens if your patient comes in and you measure them with your thermometer and they're not measuring at a fever, but your patient is telling you, you know, yesterday I measured myself at this temperature. I did have a fever yesterday.
Right. So fever is something. So the definition seriously of fever is anything over, if I still remember very well, 100.4 Fahrenheit, if I'm not mistaken. So anything above that is called fever, right? So if you look at the Center of Diseases, they only classify fever as anything above that, right? So if you think about subacute fever or anything like that, that's called raised temperature. But that's okay. That's still not a big deal. I mean, this is a very nice, beautiful discussion. But if somebody tells you that yesterday I'd had fever, today he's not feverish, right? So the reason what caused him fever has gone. Apart from the fact he's got intermittent fever, then you have to think outside of the box and then maybe think of it as to be like malaria or something like that, right? But if it's something, you know, you can have intermittent fevers like in a different scenarios and different reasons. But if you really think about fever is 100.4, right? And please correct me, guys, because I'm an old guy, right? Very difficult for me to remember numbers, but this is one number that I'm still probably aware of. But it is a raised temperature. And the reason, and I hear you, doctor, I hear you. But if we're going to define the answers, right, about why do we give antibiotics, we have to watch what we say, right? We have to watch what we say. Why am I saying that? Because as you said it nicely, and maybe I will save that argument until the end, but it's got to do with why are we giving antibiotic? What if that patient develops pseudomembranous colitis, for example? But then in your note, you said that you have a low-grade fever, right? Or you had a mild fever. Then I'm going to look at this. I said, what is your rationale behind it? Define up your low-grade fever. What does it mean? Right? So you have to think at it from this perspective, but we'll have that discussion at the end.
So this question, how long is calcium hydroxide dressing effective for as a canal medicament between appointments? 2 weeks, 4 weeks, 6 weeks, 8 weeks, or 3 months? We've got varied responses in the poll results. So next question, in an 8-year-old patient, the most appropriate treatment of a vital first permanent molar with closed apices and a large carious exposure is, this one should be pretty clear. Next one, in a 4-year-old child, the primary central incisor has discolored following a traumatic injury. So the treatment of choice is A, pulpotomy, B, partial pulpotomy, C, pulpectomy, D, observation, and E, extraction. Next question. Pulpotomy is the treatment of choice in carious pulp exposures of A, asymptomatic vital teeth with completely formed apices, asymptomatic vital teeth with incompletely formed apices, asymptomatic necrotic teeth with completely formed apices, or asymptomatic necrotic teeth with incompletely formed apices. This is the last question in the poll, and then there's two more after this that are not in the poll. So this is which one of the following is the most appropriate initial treatment for internal resorption? A, pulpectomy, B, pulpotomy, C, pulp capping, D, apicectomy, and E, extraction. And now we'll do the bonus question. So these two questions are not in the poll. So try to pay attention. And if you want to put in your answer in the chat, please feel free to do that. So this is question number 11. In primary teeth, a pulpotomy using calcium hydroxide, A, will cause an acute inflammatory reaction. B, is successful treatment in 90% of cases. C, will cause internal resorption. D, is the treatment of choice for small mechanical exposures. And E, will stimulate apical closure. And this is the last question. What is the most appropriate endodontic management for a 9-year-old patient for tooth 1-1 with an open apex and a necrotic pulp? We're getting mixed answers to this one. So some people are saying D, some people are saying B. So let's go over from the beginning. So we went over this one. So I'll start here. What is not an indication for pulpotomy? So the answer is E, spontaneous pain. This question is very much relating to actually the first question. They kind of go hand in hand. And so as we discussed, when a patient has spontaneous pain, they're having throbbing pain, it means the infection has probably spread deeper than the coronal portion. And so for that reason, a pulpotomy is not going to be sufficient to manage their pain. And that at that point, you would opt to do a pulpectomy. This question, what is not a contraindication for pulpotomy? The answer is simple. Pulp exposure due to caries is not a contraindication for pulpotomy, but everything else here is a contraindication. So taking note of E, the excessive hemorrhage. Oftentimes we may treatment plan for a pulpotomy. We may, explain to the patient, we're going to do a pulpotomy. We go into the coronal section, but then we spend a certain amount of time trying to stop the hemorrhage, and the bleeding is not stopping. And at that stage, then you would decide to do either a pulpectomy or an extraction. Because if you can't stop the bleeding, then you can't do the pulpotomy. This one, what is not an indication for pulpectomy? So the correct answer is B, underlying cyst. So everything else, you can do a pulpectomy pretty much, almost like any sort of pathology or pathosis with the tooth, you can still do a pulpectomy, except if there's an underlying cyst, because at that stage, the management for a cyst is very different. And you'd have to look at treatment options for managing the cyst, not the canal. What is the best antibiotic for post-op endodontic management? So it is, I think you called it clavulin here in Canada, which is amoxicillin with clavulanic acid. Or alternatively, you can always just do amoxicillin with metronidazole, is the other very good antibiotic for endodontic management. When should you use post-op antibiotics? So in this one, the answer was E, 9-year-old with irreversible pulpitis with acute apical abscess, facial swelling, and a real fever, which I will change right now, and fever. There we go. And I will keep the other ones as mild fever because you would not do post-op antibiotics for a mild fever. You would only do it for a real fever. Thank you for that correction, Dr. Hetland.
No, listen, listen. It's a beautiful presentation. I just want you guys to be protected. That's the only thing, right? So definition of fever is anything above 100.4, right, Fahrenheit. So anything above that is considered fever according, I mean, if you really think about it, who defines it? You have the center, look, when we had COVID, for example, where did our references came from? It's the center of diseases, right? So the center of diseases defines only fever. It doesn't break it down into stages. So this is why it is, and I know it's so random, this fact, but this is one of the very few random facts that I know. Sometimes you have to be specific. A low-grade fever is the way, it's probably a terminology that it's more or less reserved for malaria and things like that, right? Or something like that. So there is quite a bit of types of fever. There is intermittent, there is continuous, there is nightly ones, right? So, but the ones when we are referring to, I think fever by definition is anything above 100.4. When you have 100.4, then you really have fever, right? Everything else, maybe, I don't know, high temperature, you know, define it, but it's one of those things. But anyways, we'll talk about it in a minute.
So, Dr. Hassan, based on that, like if a patient comes in and I'm taking a history and I'm asking like, do you feel like you have a fever or do you think you have a fever? And they say yeah. Would you recommend to dentists
There
to
is no such
actually
a
have a
thing.
thermometer and measure the
Exactly.
patient?
I think you should have a thermometer.
Okay. I don't think
I
I've
think
ever
all of
seen a
our I think
dentist
all
do
of
that.
our offices from the COVID days have one.
Sorry?
I think all of our offices from the COVID days have one. All
Okay.
of them. You
Okay.
just have to
That's
make
good to
sure
know.
that they have batteries. That's
Yeah.
it. Right? We had an infrared ones. You remember it was one of the requirements. So they all have them.
Yeah.
All of them have them. So it wouldn't be a problem.
Okay. Okay, so this question, how long is calcium hydroxide effective? There were many mixed answers. So the answer is technically, correct answer is D, because you can leave the dressing in for 2 months and it will be effective. However, it's most effective for 2 weeks. So those first 2 weeks will be the most effective. But up to 2 months it will still have some benefit. So the answer here is kind of tricky. It's between A or D, depending on what you want to consider the most correct. But yeah, 2 weeks is the most effective, but it still has benefits up to 2 months. That's based on my knowledge. So if anyone has different knowledge, feel free to share. In an 8-year-old patient, the most appropriate treatment of a vital first permanent molar with closed apices and a large caries exposure is B, pulpectomy. I believe majority, everyone got this right. So in a 4-year-old child, the primary central incisor has discolor following a traumatic injury. The treatment of choice here is D, observation. Especially because it's just discoloration. We don't know exactly what's going on. In an ideal scenario, you would do more investigations and try to gauge what is the state of the pulp. But because there's been a traumatic injury, you would observe and revisit in 2 to 4 weeks, I believe. And then at that stage, after a little bit of time has passed, then you would reassess the tooth. I think everyone got this one right. So pulpotomy is the treatment of choice in carious pulp exposures. The correct answer is B, asymptomatic vital teeth with incompletely formed apices. So the idea here, and if you guys want to go back and read the journal article that I based the presentation on, they do have quite a number of case scenarios of like real patient cases. And they did show, for example, one scenario where it was a carious pulp exposure and they did a pulpotomy and that tooth ended up remaining vital for many years after that. And there was also one very interesting case in the article where they actually did a partial pulpotomy, not a full pulpotomy. And even in that tooth with the partial pulpotomy, that tooth remained vital for years after that on the follow-ups. So I do suggest, just taking a quick look over the journal article, or at least just reading those case examples they gave, because they were very interesting. Which one of the following is the most appropriate initial treatment for internal resorption? So the correct answer here is A, pulpectomy, in order to remove the cells that are causing the resorption. So pulpotomy would not be enough because the resorption would just continue. It wouldn't suffice. Okay, so in primary teeth, a pulpotomy using calcium hydroxide. I think everyone got this one right. So the answer is C, will cause internal resorption. So even though I've found in some studies that the success rate with calcium hydroxide is between 86% to 100%, but the main disadvantage is that when it's used in primary teeth with hyperemic pulp, it can come in contact with the vital pulp tissue, and that's what will cause internal resorption. And the last question, what is the most appropriate endodontic management for a 9-year-old patient for tooth 1-1 with an open apex and necrotic pulp? So most people said B, apexification, which is the answer that I have. But I did see some people put down revascularization. So if you guys want to, maybe join the discussion and perhaps let us know why you would do revascularization, enlighten us. Maybe we don't know much about that. Speaking for myself only. I think Dr. Pore and Dr. Marco put down revascularization.
As a matter of fact, there has been some evidence, right, that shows that. But, I've read the article, by the way, guys, Peter and Dr. Pore. But, the problem is this article doesn't relate up to the everyday dentist. It actually relates up to situations where the studies were done in universities and the cases were done by specialists, or not just in training, but rather than a full thrust like the specialist. So maybe in their hands it may work, but let's just think about it in a serious situation, right? Is it worth it? Maybe, right? Maybe, right? But I don't know, Dr. Sally, I'm sure Sally knows quite a bit about this. I don't know if she's listening to this or not. I think at one point in time, we had that discussion. And I think that what they do, they actually clean everything and they over instrument and they induce bleeding and then they close and then they revisit, and they found that there is some pulp tissues regenerations been going on, but I'm not quite sure if that is happening when you have an open apex or when you have a closed apex. But I'm not 100% sure. I think with more open apex, your cells is still formulating and you probably have a better chance. But I don't know if Lisa or Sally has any ideas about that. But I'll flip the article for you, and just let you have probably a better read and more an informed decision making on it. But I do agree with you. Probably both are correct. I mean, there is no right or wrong answer. But if you're talking up from a person who is an everyday dentist, probably apexification might probably work better, but I'll leave that to you guys.
In my opinion, unless I read like a statement or some sort of standard of practice by the American Academy of Endodontists regarding revascularization, it just means that studies are ongoing and maybe they just haven't developed that protocol yet. So, yeah, for the day-to-day practice, it's, in my opinion, apexification. Unless something comes out from the AAE that suggests otherwise.
Absolutely. Absolutely. It's 10 out of 10. And if you really look at the article, the first thing you're going to do, those are like the biggest name in the industry, trying to do something in a situation where the patients are in the university. Like, you know what I mean? You've got everything working into your favor, and they're going to do like probably about 8 or 10 cases. And I don't know if they have mentioned any cases that failed. They've only mentioned the cases that succeeded. I'm a little bit skeptical about those type of studies. So as Sally said, unless if there is a position paper, you will only gonna stick with epixification.
Mhm. We'll just wait for AAE to pass it as a procedure, I guess.
Okay, so that brings us to the end. So now it'll open up for a general discussion. If anyone has any contributions, any comments or anything like that, please definitely do, voice your opinions. And thank you all for listening. I hope it was a good review for everyone. I hope everyone took something out of it and benefited a little bit. And thank you for listening so attentively.
Thank you, Dr. Iyat. You know what? I probably want to ask a few questions to you. First of all, and probably want to engage everybody as well. And I'm very happy to, probably this is a way for me to meet my new associates, see their way of thinking and how they address certain scenarios. I mean, first of all, do you really feel, and maybe Dr. Sally as well, Dr. Lisa, come into this conversation, do you really feel that lack of time is a good indication for having a procedure? And what different of time? Because the way that I'm thinking about it, if you're going to do a pulpectomy, and I want to know how you define it. When I went to dental school, pulpectomy was defined as instrumentation to file number 25. I don't know what is it right now defined up, Dr. Sally, if that has changed at all or not. And that is, in my opinion, the way that it was described in your discussion as complete instrumentation, right? So the only difference between a pulpectomy and a complete root canal treatment was the fact that you could not leave. You cannot, it's the reason why they say 525, if I still remember very well, is that you are not able to clean and shape correctly. So you're always going to be end up with some remnant of the pulp tissue if you don't clean to number 25. So the question here, is that really an indication? How much extra time are you going to take, right, in order for you to finish the complete instrumentation out of your patients versus up to do a pulp chamber? Because you de-roof the pulp chamber, you identified all the canals. How much time extra are you going to do successfully, right? If you mention up the statistics, right, for the purpose, it's all about the purpose, right? So you're going to eliminate pain, right? So in the case for the patients, either to make a decision whether he wants to save the tooth or not, whether he want to carry on with the treatment or not. But eventually, I always say patients who are in pain don't think clearly. So you're giving the patients enough time to make a decision. Like, what is the true difference, right? You might end up doing a pulpotomy and end up with probably more pain, right? So the question here is that, A, are you going to elaborate into the diagnosis part? Because I really feel it's very important for you to elaborate on the diagnosis portion. Does all diagnosis warrants that or not, right? Yes, I understand you saw up a fracture and you decided to do that, and that's fine, very good. But what if the patient doesn't have a fracture? What if the patient does have an irreversible pulpitis? Do you think pulpotomy would work?
So
I don't know. I want to hear opinions, right? And want to see what you guys think.
Background on why I did this article was because our very own Dr. Lewis was complaining of a few incidents where patients were seen on an emergency basis and ended up on his chair because associates thought that they did a complete pulpectomy, but in fact it was only partial pulpectomy. And he thought that it was very important to educate everyone and ensure that they know the difference between the two and always ensure that their pulpectomies are complete. And he is one of those who prefer complete instrumentations rather than just a complete pulpectomy. So a pulpectomy, and he did join one of our or two of our endo discussions last year, and he did specify the difference. So pulpectomy is basically pulp extirpation only. Instrumentation is when you enlarge the pulp chamber by a minimum of size 25 file. And that is in his definition, and everyone, all other endodontists' definition the complete instrumentation, or like the minimum. It's not really complete instrumentation for incisors, for example, but it's the minimum that you need to reach on that emergency appointment. And moreover, he thought that if someone is not confident enough to reach that file size 25, he prefers if they only did pulpotomy and left the root portion undisturbed, because this will cause less pain and less flare for the patient before he sees someone who's more experienced and who can finish the root canal. So yeah, he actually mentioned endodontic emergencies. If you're not really willing, or if you're not confident to finish that root canal, then pulpotomy is all you need to do. Because if you're actually doing a complete pulpectomy and instrumentation, then you should be able to obturate and just finish the case.
Thank you very much. This is what I thought, because on my days, a pulpectomy doesn't mean like just putting an instrument and that's it. In my days, it was till file number 25 a minimum, as you said yourself, and I still do believe that it's valid, because it's all about the purpose. What are you trying to achieve? You're trying to relieve the pain, but you're not going to be able to relieve the pain if you removed partial of the pulp chamber or partially, on the like the root pulp. Right? You should actually clean and shape very well in order for you to try to reduce the amount of pain that this patient have. But you know what would be nice, maybe, if it's okay with everybody, is that if we can, and I can speak to Dr. Lewis, and maybe we can arrange a follow-up session, not like to replace up a schedule that Dr. Lisa and Dr. Sally has done, but maybe an extra session where he will have a nice discussion with us about this and see what his thoughts about this is going to be, because I feel that it's really very important for us, because this is something, as Dr. Iyat nicely has mentioned to us, and we know that for a fact, is that 60% of the times most of the patients come back for us because of pain, and that pain can be of the endodontic origin, right? So dealing with those type of emergencies is very, very important, right? It's the rule of the thumb, right? Patient walks in, he's in a lot of pain, you ease up the pain. Guess what would happen? The patient's going to believe in you, and he's going to come back, and he's going to bring his neighbors and his family and the dogs and, and everybody, right, to come and see you. So it's really very important that we know how to manage it well. Another discussion that I would like to, point out is that you've pointed out a little bit about antibiotic. There is no such a thing as, what's your thoughts about antibiotic? We have guidelines that we go for. And those guidelines that Iyat has stated out very clearly is that whenever you have a systematic involvement, you give antibiotic. If you don't have systematic involvement, everybody else discussion is a myth. It's actually a myth, right? So if there is no systematic involvement, you're not supposed to give antibiotic. You give antibiotic, guess what would happen, right? Patient could develop anything, and there is nothing to defend you. Right? And it does happen. And I've seen it so many times, right? Where the patients ended up in the hospital because of pseudomembranous colitis, right? You know what? And unfortunately, it was an undefendable case, right? Because there's nothing in literature that will warrant why the patient would take antibiotics. So be very, very resistant to your, eagerness towards giving antibiotic randomly. Because what would happen is that the antibiotic did not reduce the pain. What had reduced the pain was the ibuprofen, more or less. Is ibuprofen that what had reduced the pain? It's not the antibiotics, right? So, this is probably in a nice as well discussion that we're going to have. So, Dr. Iyat, what are your thoughts about this?
Yeah, no, I completely agree.
Right.
That's
so
why,
what I'm
like,
going to
I
do,
kind
if
of,
it's okay with Dr. Lisa or Dr. Sally, there is actually a stewardship, like an antibiotic stewardship, that I'm going to forward the link. Dr. Sally and Dr. Lisa is going to forward it for you. And I want you to finish it. And at the end of this, they will give you a certificate. And I want you to email the certificate to Dr. Sally and Dr. Lisa. and it has about 30 questions that you have to answer. And guess what? You can do it as many times as you want until you get 100%, right? And then you email it to us. If you do that, then you'll get into line with what is supposed to, what situation do you give antibiotics or not. I think this is not a bad idea whatsoever. And if we do that, then we can be 100% sure that you understand the concept. Don't be tempted to give antibiotic. Don't be tempted, okay? Because eventually what would happen is that we'll get yourself into trouble for no reason, right? And it's always easier to explain that you didn't give antibiotic because there was no systematic reasons. But you know what I would do is that I will educate my patients and I will say, listen, at this stage right now, you don't need antibiotics. You may need it though, if you develop these symptoms. If it happens, come back to me and I will give you antibiotics. And there is nothing wrong with that. But there is something wrong if you give antibiotic without a purpose, without a reason. It will become very hard to defend. Okay?
So the reason I brought it up is because having worked 8 months, because like you said, they emphasize stewardship a lot in dental school, especially I guess, I don't know if it's a recent thing, because what I've noticed since graduating is I've noticed a lot of older dentists are much more likely to give antibiotics. So I thought it would be a good discussion. I called it a discussion because I wanted to see what everyone else, but I know I agree that discussion is not the right word.
Maybe the old dentist can do a proper extraoral, intraoral exam, can evaluate the lymph nodes enlarged. Maybe he can see there is a little bit of trismus. Maybe he will notice a little bit of difficulty swallowing. Okay, maybe he will notice a little bit of swelling, right? So if you actually notice these things, then you're absolutely correct. Remember, there are certain things that you can measure quite easily, right? Pulse rate. If your pulse is tachy, then guess what? Yes, you're antibiotic indicated. If you're feverish, definition above 100.4, then yes, you give antibiotic. Those are indications for it. Guess what? Surprisingly, if you measure 100 point, if somebody comes with a root canal pain that didn't put him to sleep, don't you think he's going to be tacky? I bet you on everything he will be tacky, right? You just have to measure his pulse. You measure his pulse, then you have a justification for you to give his antibiotics, right? If you have done his temperature, which is so easy to achieve with what we have, guess what? You can actually give antibiotics. But if you don't, then guess what? Then you shouldn't. Don't care how old you are, how experienced you are, right? You shouldn't, okay? And I'm sure that Lisa and Dr. Sally is going to be overwatching you guys. So make sure that you don't. Okay? All right. Any other things? People, any other questions for only the troopers that are still there? Any other questions for us? Peter, I want to hear from you. I haven't spoken to you. They told me a lot of good things about you, though.
I'm glad to hear it, Dr. Hassan. I mean, no particular question, but my consensus with the pulpotomy, pulpectomy is maybe it's just personal preference, but I tend to lean more towards the pulpectomy. I've had a few cases where, and that's the major. I'm sure everybody's had the same situation where finances comes into play. They come in, they're in a lot of pain. They don't want to undergo root canal treatment, or it's not covered, but they want to get out of pain. So if I'm going to go ahead and open up that pulp chamber, I find that just going through and instrumenting those canals and cleaning out at least the majority of the pulp just, does a better job for most of my patients than, just de-roofing the pulp and just giving them medicines and leaving them. And sometimes even, like I said, especially with rotary nowadays, it just makes it a lot smoother just to access the pulp. Do at least some sort of canal orifice opening, get your red, wave 1 file and just go into the orifice, some sodium hypochlorite, and just, get your cotton pellet and close it up. So that's just my take on the topic.
I really think pulpectomy is the right way to go. And it's all about the time difference, right? And I really don't see a lot of time difference unless if a skill. So what Dr. Sally has mentioned, Dr. Lewis think that the skills needed sometimes somebody's not 100% sure that he can do a full pulpectomy, he should just do a pulpotomy and things like that. And I think sometimes what he's referring to is the things that could happen if you do a pulpectomy, like stripping, like perforation, like over instrumentation and all that stuff, like which I agree with him, but that shouldn't be the reason for. Dr. Khalid, thank you very much for that beautiful, presentation.